So welcome back to our Machine Learning and Economics Summer Institute. This morning, we are very fortunate to have Ziad Obermeyer present. Ziad, floor is yours, and I will take questions in chat. We can't hear you yet, Ziad.
I wonder if that has something to do with this mute button that I just unclicked. Let me dive right in and say that, well, I'm going to talk about applications in health. And I think that there's a way in which kind of we typically see machine learning applications in health that I think are very straightforward. Doctors make a bad decision. We're going to train an algorithm. We're going to fix the doctor. And I want to try to deepen that a little bit more today and show you that I think the potential of machine learning in health is actually much, much deeper than that most common application. But let me first start by saying that, we've talked a lot, and I think that we're at a transition point in the course today where we're moving a little bit more from the methodological contributions over the past couple of days and into the content topics over the next few days. And so let me kick that off by making an observation about how you find prediction problems. So over the past few years of your PhD program or your faculty life, I think it's safe to say that anyone who's been anywhere near applied micro has just developed this amazing sense of like how to spot quasi-random variation in something. And it seems like, when you just look at all the papers that are being published, it really seems like a key part of a lot of papers. But that wasn't always the case. And it's in fact quite a recent phenomenon. And I think to Sendil's point in the first lecture, fields change very quickly. And I think you want to be attuned to how this field might change, and you want to be ahead of that curve. And so I think what I want to suggest is that in the same way that you've developed that sense of, when you find some idiosyncratic policy that's going to give you random variation in something that you can use to write a paper in a causal inference way, you can also start to develop that muscle for finding prediction problems for these kinds of settings where the key unknown is really a variable that you can predict rather than a fact that you can estimate. Now, how do you do that? Well, I think there's one answer that's a similar answer to how you find as if random variation, which is that you just have to spend a lot of time reading about and immersed in an area and get into the details of a data set or a problem or a decision maker's dilemma. There's another important skill, which is developing a taxonomy of the types of problem that machine learning can be applied to. And today I'm going to talk about a testing problem. A problem where the decision maker has to get information. And testing problems are great machine learning problems. They're also very common because if you think about what an audit is, whether it's taxes or restaurants, that's a kind of test. Anytime you're moving information around from the future to the present or from some other person to the decision maker at hand, you're going to find great machine learning applications. Now, what do you do when you find one of these prediction problems? Let me also make an analogy to causal inference papers. Even in papers where the key parameter is a beta, that is not the paper, unless you happen to be publishing in a medical journal where you can just report the beta and call it a day. The primary interest is not just the number, but what it teaches us about the world. And I think that there's this sense that at least I had for a while about prediction problems, which is like, I don't know. I mean, these feel like just these engineering kind of problems. And I've trained something to recognize a face or do whatever. Now what do I do with it? But in the same way that beta is the seed of a broader lesson that I learn about the world, I think Y-hat problems can actually teach us a lot. And so I'm going to try to show you by going through this paper about how doctors test, how much we can learn from building a Y-hat and integrating it into this landscape of the decision that we're interested in, both about how our healthcare system works and where inefficiencies lie, and about how physicians think. Okay, so let me start with the decision maker's dilemma. And so this is a dilemma that doctors face in the ER. We're going to be talking about it in the ER, where patients come in with a variety of symptoms that can be pretty common, like nausea or chest pain. And the problem is that even very severe heart attacks can have these very mild symptoms. And so it's a huge problem because the cost of a missed heart attack is very high. But at the same time, these symptoms are so common that you could feasibly test 90% of the people that come into the ER because they could have a heart attack. And most of those people don't have a heart attack. So you've just paid the costs of testing without getting the benefit. The test in question is, I'm going to group two tests together. One is a stress test and kind of related things where you put someone on a treadmill, you monitor their heart. And the most important one is an invasive procedure. It's a cardiac catheterization where you stick a metal tube into the heart and you directly visualize whether there's a blockage. So what you're looking for is the heart, like every other muscle, has a blood supply and it has coronary arteries that deliver it blood. And a heart attack is a blockage that forms in one of those arteries and it stops blood flow from getting to the heart muscle and leads to death of heart muscle, which can lead to death of you and a number of long-term side effects. So these tests are really important, but of course they're invasive and they're expensive. And so that's the dilemma that we're going to be talking about today. So testing is a really nice machine learning problem because of the following property. The benefit of the test ex ante depends on its result ex post. So in our setting, to a first approximation, a positive test is great. It's very useful. It reveals the blockage. It unlocks this huge return to treatment. Whereas a negative test is largely wasted. You expose patients to costs, both financial and actual health risks, and the negative tests don't lead to any treatment benefit, so you just paid the cost. So the doctor's task, intuitively, is before you subject someone to these expensive and invasive tests, you should predict the likelihood of blockage and test only above some socially optimal threshold. So to be very kind of concrete about the model of testing that we'll just use to think through this problem, imagine patients are drawn from some distribution of X's and Z's. We observe the X's. They're in our data set. The Z's are things that only the doctors observe. And that blockage is going to be a function of both the X's and the Z's. Physicians, of course, are going to decide who gets these costly tests. If the test is positive, they're going to treat all those patients because you wouldn't subject someone to the costs and risks of the test unless you're going to treat them if the test is positive. And if you treat those people, you're going to get this large benefit that's been established through decades of randomized trials for treating new and acute heart attacks in the ER. Now, let's say someone has a blockage, but you don't test them, and as a result, you don't treat them. Those patients are going to have adverse events in the short time window after that ER visit at a higher rate than the base rate. So those are the kind of the basic assumptions. In the paper, you can kind of like read through how we get here, but all of that implies that the optimal testing rule for society is to test if the risk of blockage is above some threshold, and the threshold we can write in terms of basically like the benefits relative to the costs of the testing and the treatment. But physicians might not be using that optimal testing rule. And in particular, they might differ in two ways. The first way they might differ is that they're not using B of X comma Z, which is the objective likelihood of blockage. They're using their own human function, H of X comma Z. And so they're going to test if that is above the threshold. And the other problem is that physicians also might have a private incentive to test more. So they're going to have something that lowers their threshold for testing and leads to testing people that they shouldn't if they were using the socially optimal rule. So very simple, that's kind of the way we're thinking about that model. The core insight and the core of our empirical strategy is the following two observations. We're going to define over-testing with respect to the yield of testing. And so this is kind of like well-trodden ground in the literature. If we find a subgroup of patients where the yield of testing is low, below that socially optimal threshold of costs and benefits, eliminating all of the tests for those people is going to increase welfare. These people are, the cost of the test is too high relative to the benefit. And so even if one or two people or more than one people is actually above, if we find a set where on average that's true, then we should eliminate tests for all those people. Conversely, if we find untested patients who have an adverse event rate of above some threshold, again, balancing costs and benefits, then adding tests for all of those people is going to increase welfare as well. So we're going to work with these two definitions of over and under testing, and we're going to find these subgroups using a prediction algorithm. So the specific thing we do is we're going to form explicit predictions on the outcome of testing using machine learning. So among people who get a test, we're going to predict the outcome of testing. And that's going to let us find subgroups of patients in whom physicians might have made a mistake. So we're going to use the algorithm to define subgroups of patients, but we are not going to use those predictions as an arbiter of the truth. So if we see that physicians are testing low-risk patients, or if we see that they're not testing high-risk patients, we're not just going to assume that the algorithm is right, because the physician has a huge information advantage over the algorithm. They see a bunch of stuff that we don't see. We're going to get into that later. We're only using that predictor to identify patient groups based on X, and then we're going to look at their actual health outcomes, the yield of testing in the tested, the adverse event rate in the untested, to judge actual errors. One interesting consequence of this strategy of just using the algorithm to identify patient sets is that the nature of the predictor almost doesn't matter. It could be any kind of predictor, and if it's a bad predictor, we're not going to find patients that fit this definition. If it's a good predictor, then we will. And the physician's information advantage also doesn't matter here, because we're not imputing any outcomes. We're looking at realized health outcomes in both the tested and the untested people. Let me just pause there for a second and see if there are any questions in the chat that I have missed.
Wait, Ziad. Yeah, there was one question. Ili, do you want to ask your question yourself?
Yeah, sure. I just had a question about the goals of the prediction. How does this compare to taking sort of like a bandit style approach where we would want to test kind of uncertain cases as opposed to cases based on their probabilities?
So yeah, interesting question. I mean, here, so yeah, and I'll just kind of go back to a couple of themes that I think Danielle and Susan both raised. Here, we're using a standard supervised learning prediction because we're going to assume that the objective function is the right one, and that we're going to just be maximizing the yield of testing. And so you could easily imagine kind of like a different set of assumptions where we'd want to explore in different groups, and that might make this better. I think that's another equally valid approach. We went for a simpler one here. Other questions that came up?
They're not in the chat right now. Are there any directly from the audience? I don't see any right now, so let's continue.
All right, let me keep going. Yeah, just please interrupt me. So here's how we just set up the prediction at a very high level, and we can kind of get into more details later. If you imagine the patients, we're using electronic health records from a single hospital, and then we're going to replicate this in national Medicare data. So if you imagine, we see electronic health records from over time, and we're going to imagine that time 0 is when that patient walks into the emergency room of this hospital. And so we're going to look over the 2 years before that visit, and we're going to construct a very large number of candidate features to build this algorithm with. How did we get to 16,000 features? So each individual diagnosis code that appears over that period is going to be a feature. Those codes are nested in hierarchies. So each of those hierarchy levels are going to be features. Laboratory studies that are this very complex time series can be converted into those features, as well as kind of vital signs and elements of notes and things like that. So we have a very large number of features to draw on here. All those get turned into variables. And then we're going to churn all of that together to predict in this 10-day window, in and right after that ER visit, who gets tested, and of the tested people, who's going to get treated. So we observe who's tested, so we can distinguish between the tested and the untested. Among the tested, we're going to predict the outcome of testing and see who's high risk and who's low risk. So we do this in about 250,000 ER visits over a 4-year period. The mechanics are, it's an ensemble model that combines a tree and a lasso, and we do this all in a 2/3 random sample of patients. So patients have multiple visits, so we're very careful to keep those patients together in either the training or the holdout set. And we're going to predict the yield of testing in the tested, and then we're going to use that function to generate predictions in that 1/3 holdout set. So all the results I'll show you here are from that holdout set. In that holdout set, we've identified sets of patients based on their predicted risk. So bins of predicted risk, to be concrete, And in each of those bins, we're going to look at health outcomes to judge whether a particular set of patients was over or under tested. So let me start by just telling you something about the average yield of testing. This is sort of a little bit higher than when you look at other studies, but it's pretty low. So only 14% of people who get tested have a positive test and get treated for heart attack. Despite that low yield, it's so important to treat heart attack that if you use all of the sort of normal assumptions in the literature to turn that into a cost per life year, you actually still get an estimate that's pretty cost effective at about $90,000 per life year. The rule of thumb is kind of around 100,000. So this is actually on average looking pretty good. Now let me show you that same quantity, but by predicted risk. So on the x-axis here, we've taken all the patients in the holdout set and we've divided them into 10 sets based on their predicted risk. So these are just deciles from lowest risk on the left to highest risk on the right. And now on this, on the y-axis, I'm showing you the yield of testing. So who has a positive test among those who were tested. And you can see that this actually is sloping up pretty dramatically. And so that means that among the people that doctors decide to test, we actually do a pretty good job of identifying who's going to have a positive test. In the lowest bin, that number, so there's a pretty big range from 1.6 in the lowest bin to over half in the top bin. So we're getting quite a good spread in the predictions here and quite a big difference. And I think, again, if you look at the bottom 50, 60% of people, remember, these are all people that doctors have chosen to subject to the costs and the risks of testing, but they have a predictable likelihood of having a very low yield of testing that we're able to see ex ante. So in the top bin, by contrast, things are looking very good. So over half of these patients are having a positive test and getting treated and getting the benefits of treatment. And so, I've been talking about the tested, but one observation is that if testing is so cost effective in these people, an interesting question is, how often do doctors test these people? So we can generate predictions for everyone in this holdout set, not just the tested people who are shown here, and just calculate, oh, sorry, I forgot to mention, the cost effectiveness is also hugely different. So over $1 million per life year in that lowest bin, and very, very cost effective at 46,000 in the top bin. Now we can calculate in that top bin where it appears very cost effective, what fraction are getting tested. And it turns out that actually only about half of these apparently very high risk people are getting tested. So that finding is not a new one. So this looks very similar to a finding that Jason Abelak and Leila Abba got in a really nice paper from 2016, looking at a very similar setting, testing for pulmonary embolus in the ER. So physicians fail to test apparently high-risk patients. I think the problem is, and the reason it is hard to make the leap from this fact to conclusively demonstrating undertesting is that physicians have access to a lot more information than we do in our statistical model. So they can ask the patient about symptoms, they can do a physical exam. They also have access to these test results that they do in the ER that we can't use because they're not present for all patients and because they're kind of downstream from the decision. So for all of those reasons, we might find a patient and say, oh, wow, this patient looks really, really high risk. But the physician could have very, very good reasons from all of the stuff that we don't see for leaving them untested. So if we actually went and tested those people, we would find that they could be extremely low yield. This problem is compounded by the fact that we don't know the truth for that person. So in the tested, we can look at the test result to see who's right, the algorithm or the doctor. So that's the health outcome we look at in the tested. In the untested, we don't have test results. And this looks a lot like the bail situation where if someone gets sent to jail, you don't know if they would have failed to appear for their hearing. So let me just walk you through the two strategies that we use to try to get around that similar problem. The first is that we have the luxury of being able to look for a different health outcome. So we're going to look for signs that some of these high-risk patients were untested and then also undiagnosed with heart attack, which is going to raise the predictable adverse event rate in the next 30 days. And this is kind of using insights from the medical literature on what an undiagnosed heart attack would look like in electronic health record data. And the second is that we're going to exploit some quasi-random variation in who gets tested. So here's the first one. So the first thing to stress is that that I'll come back to in a second is that we're excluding a bunch of people from the sample, people in whom doctors might have hesitated to test because of poor health. So anyone over 80 years old, anyone with cancer or dementia or other serious illnesses, anyone who had a heart problem recently diagnosed, we take all those people out of our untested sample. We're also going to take out of our sample anyone who at the end of that ER visit, the doctor suspected of having a heart problem based on the results of laboratory testing or based on the diagnosis that they assigned. So in theory, these residual patients are going to be people who are kind of healthy, people who are not in a nursing home. They're kind of like, they don't have any obvious signs of illnesses. And when the doctor sent them home or sent them somewhere in the hospital, the doctor didn't find any evidence of heart attack or any other heart problem. So now we're going to look at these remaining untested patients, and we're going to just bin them into the same bins of predicted risk. And we're going to look at that adverse event rate over the 30 days after their ER visit. And what we find, and so here are the adverse events. These are the kind of things that happen when you have a heart attack that isn't caught and treated. You can get diagnosed with another heart attack and treated, but now you've lost a bunch of time and a bunch of your heart muscle has died. We confirm all of that with laboratory studies that show us that the heart muscle has died. You can have a cardiac arrest and get resuscitated, or you can just die. And so what you can see is that in that top bin, so this is the kind of like the highest risk bin, and this is the cutoffs are formed in the same way that we form them in the tested bins for comparability. There are 15 or 16% of people who have one of these outcomes or more of these outcomes in the 30 days after the visits. And to put that in context, so is that high or is that low? There are clinical decision rules that are implemented in lots and lots of ERs across the country. And what those rules say is that if someone has a predictable likelihood of having one of these events over the 30 days after the visit of over 2%, and that's that horizontal line. I forgot I had a pen. So this line down here, this is the clinical threshold for judging whether someone should have been considered for testing or not. And so you can see that in the top few bins, we're getting much, much higher and significantly higher than that clinical threshold rule. One thing that you might worry about is like, oh, well, are these just kind of upcoded people or people in whom doctors are just diagnosing with heart attack to get reimbursement? So we can separate those two categories out. So one is things that are potentially discretionary that depend on the doctor testing the patient and diagnosing them with heart attack. That's these things up here. But about a third of these events are actually just people dying, and this is also going up in predicted risk. So these aren't just discretionary events. These are actually people who are dying in the month after they were sent home from the ER or diagnosed with something else in the ER. And so this does not look great. This seems to suggest that people are indeed high risk. So even though these adverse event data show that high risk people are truly high risk, they go on to look like they were having a heart attack in the ER, it doesn't necessarily show that they would have benefited from testing and treatment. So here's a concrete scenario. So imagine a frail person that we haven't managed to exclude on the basis of our age or other criteria. If a physician sees that person and is very suspicious of heart attack, but says, testing and treatment are invasive procedures and it's going to do more harm than good in this person, the physician could have, again, deliberately decided not to test that person, not because they weren't aware of the risk, but because they knew that that person wasn't going to benefit from the treatment as much as we would have thought they would. So one thing that's really helpful here is that we see a lot of detail about what the physician thinks about patients in the ER on the basis of what test results are present and what tests the physician orders. And in particular, we're going to use a couple of low-cost screening tests as a proxy for any suspicion for heart attack. So if you go to the ER and you have chest pain, even if you're 20 years old, if there's any suspicion of heart attack, you're going to get an electrocardiogram and ECG done in the ER. That's a non-invasive, very cheap procedure that's even done at triage by the triage nurse. And so the ECG is one thing we can look at. The troponin is a laboratory test that gets done. Again, there's a very low threshold for doing this, even when the physician is at very low suspicion for heart attack. And importantly, these tests are done even on those in whom the physician suspects low benefit from testing and treatment, because you need to know, for example, even if you're not going to treat someone's heart attack, how bad is their heart attack? Do they need to go to the ICU? What other medication should I be giving them? So these patients in whom we don't see any evidence that the physician has ordered an ECG or a troponin are going to be a lower bound for us. So if we take out all the patients in whom physicians might have suspected heart attack and only look at these remaining ones, physicians are not aware of the heart attack risk and deciding not to test them because of low benefit. This is not private information. This is just people in whom the physician didn't suspect heart attack. So if these people are still having a high adverse event rate, that is going to be an indication that these people are high risk and not being excluded because of treatment heterogeneity. So let me just show you first the fraction of patients in our sample that don't have an ECG done. So on the x-axis here is our risk predictor. This is binned into 4 groups on increasing risk. And here we're seeing that as risk goes up, exactly as you'd expect, the fraction of people without an ECG goes down. So physicians are suspecting higher risk people more and doing an ECG more, and a similar trend with the troponin result as well. So now we're going to look at these remaining people here, the people who are in the highest risk bin, but did not have any of these tests done. So these are the unsuspected high risk people who don't get tested. And we're going to look at their adverse event rate. And what you can see is that in both of these groups, the adverse event rates are high and significantly above that clinical threshold. So we interpret this as a lower bound. So if you remove patients or you only look at patients in whom we're very sure that physicians don't have private information about either risk or treatment benefit, we're still seeing the algorithm is identifying people who are at high risk of having these adverse events after their visit in a way that suggests untreated and undiagnosed heart attack. Okay, so that is, I think if I were a reviewer, I would say that all of that is kind of circumstantial evidence. It's indirect, it's adverse event rates. And clearly, the best way to resolve this would be to run a trial. And what we want to do is we want to take these high risk patients that aren't currently getting tested, and we want to randomly just start testing them and then look at whether or not that testing improves their health relative to the people who don't get tested. That is something that we're actually in the process of building up with a health system now. But in the meanwhile, we can rely on some hopefully as good as random variation in the way that triage teams test. So you come into the ER at a particular time, and there's a particular team of people working at the triage desk. And we can link the particular team working at the triage test with a higher or lower rate of downstream testing by the physician. And so that's going to give us, once we take into account the time of day and the patient's baseline characteristics and all this stuff, we're going to be able to use that as a variation in testing rate that's going to mimic randomly testing more or less patients in a given risk bin. Luckily for us, a lot of the observable factors of these people are kind of balanced across different shift testing rates. And then even after we take into account the time of day and the risk, there's still a lot of variation. This is the mean risk of people who come in on a given shift. And this is the shift likelihood of testing on the x-axis. And so there's still a lot of variation that we see here in the predicted risk of people coming in on a shift and the testing likelihood of people on that shift. So this gives us a little bit of confidence that the variation we're seeing here is usable for our purposes. So let me show you, I've managed to draw on my subsequent slide. I'm going to show you 2 separate regressions where we're going to try to look at the effect of testing on health outcomes. And we're going to do that in 3 categories. So we're going to first look at diagnosed events. So this is, heart attack, treatment for heart attack, cardiac arrest, things like that. We're going to first look at this in the 31 to 365 days after that visit, because in particular for the diagnosed events, people who are tested, so we're going to just look at how the likelihood of testing affects this. People who get tested are mechanically going to have higher rates of this in the first month because they're in the hospital and they're getting diagnosed with a lot of stuff related to their heart attack. For death, luckily, we're going to use Social Security data here, and that doesn't have this different ascertainment strategy. So that we observe for anyone over the full year after visit. So I'd say that of all of these, I would kind of look most closely at the effect of testing on death. So here's the first result. We're going to regress these outcomes on all of the kind of like time and day and sort of date variation, as well as someone's predicted risk, and then the shift testing rate. So this is kind of the equivalent of a reduced form of health on testing. And what you can see here is that basically there's nothing. And so this, I think, might confirm your worst suspicions about the healthcare system, which is that, yes, we can do a lot more testing, but we don't get much return from testing. And even as testing rate goes up, on average, we're getting nothing in return. So this looks like the famous flat of the curve healthcare that is a well-known result. Now let me show you the results by patient risk, if you can overlook my scribbling on this slide. So what we've done here is simply added an interaction term between the shift testing rate and predicted risk, and that's down here. And what you can see here is that in particular for our favorite outcome variable, this is just someone's likelihood of dying over the year after the visit. When you look at the interaction between predicted risk and that shift testing rate, we're going to see pretty large negative coefficients here. And if you look at that high risk bin, this is like the top 1% of the tested, the mortality rate is going to go down from a base rate of 7.7 to 5.2, so a 30% reduction in mortality to people who, by virtue of when they arrive in the ER, have a higher testing rate than the people who don't. So that, I think, is reassuring on a number of levels. It's reassuring that private information is not about treatment benefit, isn't explaining our results. It's kind of reassuring about the implicit exclusion restriction here, which is that the triage team is affecting the health of these patients via the likelihood of testing for heart attack, because we're only seeing this effect in the highest risk patients. So this is kind of, I think, more direct evidence of under-testing here, in the sense that on the margin, scaling up testing is going to improve people's health outcomes only if they're in that high risk bin. Okay, so let me step back and use the last half of this lecture to go in a different direction. And this is going to be, or let me pause first and see if there are questions.
Yeah, there was one question by Jacob. Jacob, you just want to ask a question?
Sure, this may partly be answered by the lower cost options, but I was just wondering how common test refusal would be for some of the more invasive tests. And in particular, as we talk about different biases between groups, between subgroups, whether that varies. But maybe you can use the low cost options to deal with that.
Yeah, it's a great question, and let me just distinguish between two things. So, and I think this echoes some of the themes that Bo talked about yesterday. There are two separate kind of things that are going on here. The first is the likelihood of getting tested. And so there's a ton of evidence that there are predictable biases in that decision. Physicians tend to refer non-white patients for invasive testing less than they would for white patients. There's all sorts of socioeconomic things about potential refusal based on the anticipated cost, things like that. So all of those things are operating in the decision to test. Among the people who get tested, what's happening is they go to this separate catheterization facility in the hospital. They get an invasive procedure, and that either visualizes a blockage in the arteries or it doesn't. And so I think that given that the way we're identifying, that the way we're training the predictor and the way we're using that as a health outcome is to say, among those people, we don't think that there would be a lot of refusal of, for example, someone who we found a blockage. Now, should I put a stent in it to fix the blockage? So I think there's a lot less scope for bias and refusal and things like that to go in once you condition on testing. But clearly, before you do that, there's a ton of biases, and that's why I think it really matters how you specify this outcome. So if we'd just taken everyone in the ER and predicted who gets treated, we'd be predicting the product of your likelihood of testing and your likelihood of treatment, and that would be really dangerous. Does that help, Jacob? Sorry, I was rambling a little bit. Did I answer?
Yeah, no, that totally makes sense. This
Okay.
This helps my thinking about who is that untested group.
Right.
Thanks, Ziad. I also had one other comment. You mentioned here basically this missing labels problem, that you don't have the outcome of one group, which I just wanted to point out to everybody here. It sounds very much like a typical causal inference problem in that we don't observe certain outcomes and we would love to see them as well. And you mentioned experimentation as one solution. I just wanted to add one twist here and mention the fact that this is another case where it looks a little bit like causal inference, not quite the same. So the optimal thing here to do, I think, Ziad, I don't know whether you agree, but actually would be to send everybody to testing. Like we wouldn't actually need randomization. We would just need the testing results for everybody. So it's somewhat of a one-sided missing labels problem. So it feels very much similar to the typical causal inference problem that we are used to, but as a slightly different structure. Still allows us to use some similar tricks. But just wanted to point out that there's a small subtlety in that it's a bit different.
Yeah, thanks, Jan. That's a great point. And let me just add a nuance to your nuance, which is that I think that if we were purely optimizing the yield of testing, then what Jan said is 100% right. So we don't need to randomly pick people in the high risk group to test. We can just pick everyone and just see, turn over the card and see what the label is. Our situation is a little bit different because, among other reasons, one thing you might worry about is that physicians overtreat people because of incentives. So we've been using the yield of testing as a health outcome, but that's actually a discretionary thing that physicians do. And if they're overtreating people, they could be putting in a lot of stents for heart attack, but that could be not improving people's health. And so in our setting, I actually think the ideal would be to do the randomization and to randomly test people to see if increasing testing and thus treatment is going to improve health rather than just getting the label for the algorithm validation purposes.
That makes a lot of sense. Thanks for clarifying. That was helpful. All right, I don't see any other questions right now, so feel free to go on.
Awesome. Okay, so let's try to figure out, now that hopefully I've convinced you that there are some problems in the way physicians are testing, I want to switch gears and start thinking about where those problems come from. And our starting point, I think, is a very common model in health of misaligned incentives. And let me just give you a kind of cartoonish version of this model, which is that patients come to the ER in some distribution of risk, and there's some tail up here that's high risk. And there's our socially optimal policy is to find the break-even point where cost equals benefit and to test everyone above that point. So that would be the kind of, the standard model. And the problem, And the problem that we often see in our healthcare system is that because physicians get an incentive for testing people, they're going to move that threshold down and they're going to test these marginal people here that they're testing because of that private incentive. And these people are lower risk. And because we're now testing both the orange people and the purple people, we're going to get low average yield because it's that mixture of low and high risk people, the low risk people being added in because of incentives. Consider a different model where, again, physicians think they're applying the rule above, but actually they've misranked people. So the H of X comma Z is not the same as the B of X comma Z. And in this misprediction world, notice that no matter where you set the threshold here and test above, quote above, you're going to be getting a mixture of high and low risk people because the physicians think that low risk people are high risk and they think that high risk people are low risk. But notice that this also has another prediction. So notice that here we're going to get low average yield, but here we're also going to get untested high risk patients, which is more along the lines of what we're seeing and less along the lines of incentive-based models where you actually would not expect to get any high-risk people in the rest of the distribution that doctors aren't testing because doctors are approximately ranking people correctly. They're just setting that threshold too low. Okay, so let's try to get inside the physician's head. And let me start with an observation about how we normally get inside of humans' heads when we're interested in these kinds of questions. One strategy is to ask them, but who are we kidding here? If you're interested in machine learning and economics, you're not going to do that. So let's cross that off the list and go to the usual playbook, which is we're going to present the human with a stimulus and we're going to ask for a response, or we're going to see the characteristics of a patient that come into the ER, and then we're going to see what the doctor does with that patient. So there's a stimulus, it gets fed through this h of x function, the human function that we don't really observe, and then it produces some output. What we have is a different function that we actually do observe. This is our algorithm here that takes in an x and outputs, a machine decision. And I think that the classical model in psychology of sort of like in the Swiss Army knife, the first tool you reach for is basically comparing the clinical judgment, the human's judgment, to the actuarial judgment, the statistical judgment. And so this is one tool that we're going to use. But we're additionally going to use another tool, which is that we are going to build directly a model of the human. And we're going to try to interrogate that. And by contrasting the human model that we can infer with the machine model, we're going to try to get a better understanding, or at least a new way of trying to look inside that human's head with reference to a new type of statistical model, not just of patient risk, but of the human decision that's being taken in response to that patient and their risk. Okay, so we're going to examine how testing decisions deviate from risk. So that's clinical versus actuarial. And then we're going to build some models that look directly at the human's testing decision. And we're going to focus on two key hypotheses. The first one is, largely referred to as boundedness or bounded rationality. So the key observation here is that, what is heart attack? Heart attack is a very, very complicated physiological phenomenon that happens in microscopic arteries supplying the heart, the result of many, many risk factors, some understood and some not. It is a very complex phenomenon. And it's very likely that, between the complexity of the phenomenon and the complexity of the data that the physician has available to her in the ER when she's making that decision, she might not be able to process or attend to or remember all of the things that an algorithm could for making that decision. And I want to just point out a really nice paper that I think is coming out in Econometrica, but it's now a working paper called The Illusion of Sparsity, that actually looks at, I think, 5 or 6 interesting economic phenomena, both in macroeconomics and kind of, applied micro settings, and shows that the optimal model for predicting that thing is sometimes simple and sparse, but more often is extremely complex, as measured by how many variables a lasso selects or things like that to predict it. And so even though sparse models are very appealing to humans, they don't often represent these complex economic or even in our setting, physiological phenomena very well. Was there a question, Jan? Or?
Oh, just a technical question. We are still looking at the 2 bell curves. I wonder
weird.
Your slides are stuck.
I have advanced. Let me just try to. Is that fixed?
Yes, thanks.
Oh, great. Okay. So that's one set of hypotheses. And the second is that physicians make predictable statistical errors when they are using specific variables. And I think this is more in line with a behavioral Kahneman-Tversky world of predictable probabilistic errors. Okay, so let me start with the boundedness hypothesis. When we're thinking about these two objects, so there's the model of human decision making and the model of actual patient risk, we can make an analogy between two things. So when we build machine learning models, and I'll kind of use as an example Lasso, but our results aren't kind of specific to Lasso or linear stuff in any way. We often are trying to tune a complexity measure. So in Lasso, it's nice and simple. It's just the number of variables that are included in that model. And so when we're building our best Lasso, we generate best fit models at lots and lots of different measures of complexity. And then we use cross-validation to pick the best of those best fit models, the optimal level of complexity. So what we're going to do is we're going to go through that same process, but instead of just retaining the one model that does best in our cross-validation exercise, we're going to retain all of those Lasso models. And then we're going to do two things. We're going to take this set of models that vary in their complexity, and we're going to ask, how well do they predict a patient's true risk? And then how well does that same model of risk at a given level of complexity predict the human's decision to test? So that's what I'm showing you here. So on the x-axis is the number of variables that are included in the lasso. So it's going from, the average all the way to sort of as much as we can do, 1,500 variables. And on the y-axis is the R squared for predicting two things. One is risk, and that is this black curve here. And the other is for predicting the test decision, which is the orange curve. And what you can see is that in both of these things, we see a kind of, standard machine learning looking curve where accuracy goes up and up and up until it reaches a certain point, and then it goes down and down and down as you start overfitting to your training data. But notice that these curves reach their peaks at very, very different levels of complexity. So the best model for predicting the physician's test decision is at 49 variables, and the best model for predicting actual patient risk, the outcome of testing, is 224 variables. We can repeat this for depth of decision trees or lots of other kind of like different functional forms and complexity measures. And that basic result still holds. The best model for predicting risk is much more complex than the best model for predicting the human's decision. So there are a couple of interesting things about this. One is that there's a nice paper that actually suggests that humans, much like machine learning algorithms, also seem to regularize. So humans are trying to make good use of the small set of variables that they can actually process and attend to. The second is kind of going back to this old literature on clinical and actuarial decision-making. Notice that this is a very different conclusion from that literature. The basic fact that came out of that literature and that has really stood the test of time since then is that people are using too complex of a model. They're paying attention to things that are noise. They're kind of easily distracted. They update too much. And the statistical model does better by being simpler. Our results are diametrically opposed to that. Physicians are using too simple a model, and that model is actually not bad. The statistical model does better by being more complex. And I think that there are a number of things that could explain that. One is that we just have better statistical tools to capture that complexity now than we did when that original literature was being written. So let me just kind of walk through quickly a test that turns that graph into a sort of test statistic. We can just take test and the yield of testing and the tested, and we can regress both of those things on two variables. The simple risk, so this is the risk score that's built up from that simple model with 49 variables, and then a variable that's the delta between the complex risk, the best model for predicting risk, and the simple risk. And what you can see is that this incremental difference between the complex and the simple risk score is very useful for additionally predicting yield over and above the simple risk score, but it has no value for predicting the physician's test decision. So the physician's decision is accurately predicted by the simple risk score, and including that complex risk score on top of that does little to predict test, while it, of course, does a lot better for predicting yield. So that illustrates, I think, part of the story, which is that physicians seem to be using a simpler model, but you could imagine they could be getting there in a variety of different ways, some of which would be rational and some of which would not be rational. So if they had exactly the wrong weights, the opposite weights on all of the variables relative to what the machine was doing, you could imagine getting good predictability, but sort of not decidedly not rational. So we're going to take those 49 variables that are included in that simple model of risk, and we're just going to very simply correlate each variable with the human's test decision and then the true risk. And so on the x-axis of this graph is the correlation of each variable with risk, with the actual outcome of testing. And on the y-axis, it's going to be the correlation with the decision to test. And overall, these weights are correlating well. So even though this is all correlational and it's really hard to make inferences about individual variables, it does seem that the weights that physicians are using on these variables roughly correspond, or at least correlate with the weights that the algorithm would be using on them as well. But there are a couple of interesting outliers. So way up here is a variable called chest pain. So if the patient comes in complaining of chest pain, the physician is going to test way more than they should based on the risk. Age is another variable like that. Income and female sex are two ones that predict less testing than they're sort of off of the main relationship between testing and risk. So one hypothesis here is that some of these variables might be more salient than others. Physicians might attend to them more. And in particular, demographics and symptoms are the first thing that a physician sees about a patient. And they're also really a cornerstone of medical education. So this is the flagship medical journal, the New England Journal of Medicine. And this is just one example of a common phenomenon in medicine where it's like, a 54-year-old man, age, with irritability, confusion, and odd behaviors, symptoms. So these are the things that are presented. One trivia fact is that I bet you didn't know that the New England Journal wrote a case study about one of the co-organizers of this class. You should look it up. So these symptoms and demographics are really a key part of what physicians might be attending to. And so we're going to test that in the following way. So we're going to create risk scores that are formed only using these categories of inputs. So we're going to create, for example, a symptom-based risk score that predicts risk using the same infrastructure that we've been using throughout, but only using the symptom variables. And we're going to see how those predict the test decision over and above the true risk. And so here's one example. So here's our full risk predictor. That's the machine learning, our favorite model. And then we're going to add in a risk score based on the patient's symptoms alone. And what you can see is that is very good at predicting the test decision over and above true risk. So we interpret this as physicians over-attending to risk signals present in symptoms more than they should relative to what they should be doing, which is just paying attention to the true risk. We can also do this with a lot of other categories and find that things like demographics also appear to be overweighted. And the complex time series that you'd get from vital signs and laboratory studies, the risk information in those things appears to be underweighted relative to what it should be in relationship to the full predicted risk score. The last thing we do here is we actually take the symptoms and we break them into two separate sets of symptoms. Some symptoms are fitting of the stereotype of heart attack. So this is chest pain and things like that. The way we make that determination is we look at the symptom distribution in the people who are ultimately found to have heart attack. Some things like chest pain are much more common in the people with heart attack relative to the reference population, the general population. Other things are much less common. And so we can separate out empirically symptoms that are representative of heart attack, found disproportionately in the people found to have heart attack, versus ones that aren't. And when we do that, we find that the representative symptoms, the stereotypical symptoms for heart attack, are the ones that are driving a lot of that over-attention to symptoms relative to the non-representative symptoms here. Okay. Let me close, or sorry, any questions, Jan? Or anyone else?
I don't see any right now. I had one quick question. When you're talking about this complexity with respect to, for example, number of included variables, it seems that relies heavily on the feature representation in your data. So I was just wondering how you think of, any pre-processing and to which degree the features that you have in your data actually represent features that the human would understand. Like, what's your thinking around, the role of featureization here?
Yeah, so let me, I'll kind of just to say the obvious thing that I think you're thinking on, which is that we can't really take the particular variables or the weights on those variables that seriously because of everything that you've presented on how Lasso does its selection. So I think that, we're not trying to necessarily make inferences about the individual variables or their weights. I think that the complexity, though, is a more stable quantity. So irrespective of the particular nature of the 49 variables chosen, I think the fact that we can summarize the physician's testing decision with only 49 variables is probably the most important thing.
So just I do like that part a lot. I'm not worried at all about distinguishing. I was more curious whether there is like very clearly defined variables here already, because I could imagine that a human I don't know how close what is measured in your data and is a
I
variable
see.
there
Got it.
corresponds to like what you would call a human would understand as one variable. So that was I was more curious about that.
Yeah, it's a great question, and it's one that I hadn't thought about, but you could imagine that variables where there's a better correspondence between the raw data and the way a human represents it would actually be overrepresented in this thing, not necessarily because humans are attending to it more, but just because it's measured better relative to what the human is using. Is that like a better
right? Or like you could say, one way of representing the data would be to have past stints of some health condition individually coded as binary things. Another one would be just adding all of them up. And so I was just curious how you think of doing that in a way that corresponds to then saying something about how the human deals with it.
Yeah. I think that's a great question. And I think the way we handled it was not by including those individual variables, but by turning everything into risk units. So all of these things are basically, it doesn't really matter how it's represented. We turn that into a unit of risk attributable to or correlated to that set of inputs. And then we see how that risk unit correlates to the testing decision. So I think that is one way of getting around those measurement issues, but it's a really nice point. Let me close by just making an observation about what this new way of thinking about physician behavior means for our incentive testing policies. So what I'm showing you here is the test rate on the y-axis, the patient risk on the x-axis, and these are our 4 bins of testing based on the shift that you come in on, based on your arrival time in the ER. What you can see is that, so here are the high testing shifts, here are the low testing shifts. Low testing shifts, they cut these low risk tests, but they are also cutting a lot of high risk tests. This is not what you would expect to see in an incentive-based model where you should just be seeing the threshold moving down and down and down as testing goes up and up and up. So when we cut or add patients, we're cutting or adding from across the entire risk distribution. Those marginal patients are every patient, not just some progressively lower and lower risk patients. And that means that when we incentivize physicians to test less or test more, they're just going to test everyone less or more, not the low or high value patients that we're hoping. We see a very similar trend across hospitals and across geographies. So I hope I've at least partially convinced you that these errors in prediction are driving 2 kinds of inefficiencies, overuse and underuse. And I'll just note that in our preferred simulated policy, we would cut 62% of the tests that doctors currently do, but we would also add back in the equivalent of 61% of tests that doctors are not doing. And so we would cut testing overall by 1%, but the majority of people who are being tested would be different from the ones that doctors are testing today. And I think this complements a number of papers in the literature that I'd highly recommend reading. Our focus, which is unlike some of these other papers, is really on the errors that generate these prediction flaws in terms of boundedness and biases. And so the last thought I'll leave you with is that I think when you look at how people view the role of machine learning in healthcare, a lot of the ways that people talk about it is as a product. So, hospitals can now automate their radiologists. They can buy software that reads X-rays at much lower cost. And that's going to be the kind of transformational thing about machine learning in health. I think our work suggests that there are a couple of other things that machine learning can do. One is to take a completely new approach at very precisely identifying exactly how inefficiencies arise and what they look like. Had we just stopped at the average yield of testing here, we would have concluded that testing was on average cost effective. And so we should just keep testing the way we're testing. And we don't have a vocabulary for saying we should be testing these people less and we should be testing these people more. So in addition to identifying those inefficiencies, I think we can also start thinking about ways that machine learning opens up to correct them. The obvious one is decision aids, and I think that's the direction we're going in with a randomized trial. You can also imagine changing the way that hospitals and doctors are paid. So reimbursement can vary by ex ante predicted risk or ex post result, things like that. So there are many, many ways to turn these insights into real things that would improve healthcare, built on this new understanding of where exactly the inefficiencies are. The second tool, or the second use of this tool, though, is actually really producing new knowledge, new ways to understand physician behavior, new ways to try to get inside their head and understand the kinds of biases and errors that might be going on. So let me stop there and try to find Zoom again. And would love to take questions, although I think we might do it in the next hour block, unless there are any quick ones now.
Thanks a lot, Ziad. What I would propose is that Amitabh is already there. So Amitabh, while you get set up and start sharing your slides, that maybe we take 2 more questions. And at this point, also end live stream on YouTube. For everybody watching on YouTube, we will be back at 2 p.m. Chicago time with a talk by Josh Blumenstock.